we are seeing a few old villains. Then we will go on to the new villains as well. And so this will be the outline. So we will have a look at the conventional chemotherapeutic drugs, and then we will have a brief look into the targeted chemotherapy as well as the immunotherapy. And when you're talking about AKI in cancer, the risk of AKI in the first year is around 18%. And in the first 5 years, it can go up to 27%. And when you look at critically ill patients who have cancer, the requirement for renal replacement therapy is around 40%. And as Madam has explained, there are different causes for AKI in cancer. Mainly, as any situation, hemodynamic or pre-renal is one of the most important things, and we will have to look for it every time when you have a patient having AKI. And other thing is that the AKI is directly related to the cancer per se. It can be because of a thrombotic microangiopathy, like in adenocarcinoma. There can be a direct effect of the cancer resulting in a thrombotic microangiopathy. Or it can be because of a direct infiltration of the glomerulus of interstitium, as Madam was telling. Sometimes it can happen. And then the paraproteinemia, so the myeloma kidney is whenever you say onconephrology, that's the one thing that comes to your mind immediately, paraproteinemias. And then you can have glomerular diseases related to the disease, the cancers as paraneoplastic effect. And then you can have the obstructive nephropathy as well. And then the third one is the treatment-related injury seen with your conventional chemotherapeutic drugs. Now you have the targeted therapy as well as the immunotherapy. And sometimes you can get AKI in your hematopoietic stem cell transplants as well. So as Madam said, nephrectomy is one of the reasons why you have a low GFR in renal cell carcinoma patients. Then you have the metabolic complications like hypercalcemia, tumor lysis syndrome, all these causing AKIs. So our topic today would be focusing more on the treatment-related injury, that is your conventional chemotherapy, your targeted chemotherapy, as well as your immunotherapy. So we will be looking into that only. We will be omitting all the other causes of AKI because it's a vast topic, and we will be concentrating more on the chemotherapeutic drugs. So as I told, we will move on to the conventional chemotherapeutic drugs, and we will see a few common conventional chemotherapeutic drugs that produce AKI. So this is Mr. Owen. He is 69 years. He has adenocarcinoma of the lungs, and he's on chemotherapy. So it's a cisplatin-based regimen for the lung cancer he is getting. His urine output is adequate, and now he has an AKI with a creatinine of 2.3. Sodium is 133. He has hypokalemia with a potassium of 3.2, and he has hypomagnesemia with a magnesium of 1.2. It's a classical picture of a cisplatin-based AKI in a cancer patient. So you get hypokalemia, hypomagnesemia, and a creatinine rise. So it was discovered, the cisplatin, the chemical, was discovered by Dr. Rosenberg in the 1950s, actually. So he was not looking for a chemical per se, but what he was trying to understand was that he wanted to know whether passing current through a solution containing bacteria will kill the bacteria. So he was using platinum electrodes, and he was putting those electrodes into the solution, and he was passing current through the solution containing the E. coli bacteria. And he found out that the bacteria was not dividing. It didn't kill the bacteria, but it was not dividing. But after a few years only, he found out that it was not the current, it was the chemical, that is cis-diamine dichloropplatinum, that is a cisplatin, which was affecting the bacteria and not the current. And that was an accidental discovery of cisplatin. And FDA approved cisplatin in 1978 for testicular cancer. So it was the first indication for cisplatin in cancer treatment. Now it's being widely used for most of the solid organ tumors, mainly your head and neck tumors, ovarian, genitourinary tumors, testicular tumors, and non-small cell lung cancers as well. And the problem with cisplatin is that how does it produce kidney injury? So then you have to look at the picture. You can see that you have the organic cation receptors at the basolateral membrane in the proximal tubular cells. So from the blood, it enters the proximal tubular cells through these OCT2 channels. And once inside the cell, it has to go out. The main route of excretion is through the urine. So it goes out through the MATE channels. That is the multi-drug and toxin extrusion transporter. So these MATE channels, through that, the cisplatin goes out into your urine. So this is the reason why high concentrations of cisplatin can occur in your proximal tubular cells, and that results in your tubular injury and your AKI. And the main cause of AKI, henceforth, is the ATN, or the acute tubular necrosis. Since it's affecting your proximal tubular cells, it's mainly resulting in what you commonly see in cisplatin, that is hypomagnesemia. And the proximal tubular injury definitely will lead on to hypokalemia, and sometimes frank Fanconi syndrome can be seen with cisplatin. Cisplatin is also known to produce thrombotic microangiopathy as well. So it's mainly affecting the estrate segment of the proximal tubular cells because of its concentration through the OCT channels. These OCT channels and the MEAT channels are very important. We'll see that going forward as well. So how can we prevent cisplatin induced AKI? So the mainstay is IV hydration, and the usually recommendations is around almost 4 to 6 liters prior to cisplatin administration, and continuing the hydration even after cisplatin administration is there. So the second thing which we can think about is IV magnesium. It derives from the fact that, as I previously showed, the OCT channels are upregulated when there is hypomagnesemia. So if there is upregulation of OCT channels in hypomagnesemia, more of cisplatin gets into your proximal tubules and the injury will be more. So to preventing hypomagnesemia can in turn reduce the cisplatin-based acute kidney injury. And IV amifostine, it reduces the radicular oxygen-free radicals, and it's kind of a effective way of preventing cisplatin, but it's not routinely used with every cisplatin administration. Pantoprazole, I found it very when I was going through the literature, I found it very curious that most of the times when you think about pantoprazole in an AK situation, you want to avoid it because it produces acute tubular interstitial nephritis, tubular interstitial nephritis. So you want to avoid pantoprazole. But here what they say is that it is theoretically pantoprazole downregulates this OCT channels, which I had showed from the basolateral membrane. So the cisplatin accumulation into your proximal tubules is less. So pantoprazole administration, at least theoretically, may be beneficial in cisplatin, which I wouldn't recommend for all the patients. And one thing it is that though the cisplatin produces AKI, the more important thing is that 50% of these kidney injuries can be progressive in some studies. So it's very important. So they looked into other platinum compounds like carboplatin, which is second generation platinum-based compound. Then there is oxaliplatin, there's a third generation. Both these are less nephrotoxic when compared to cisplatin, but it is not as potent as cisplatin. So you cannot substitute a cisplatin with the carboplatin and oxaliplatin for all the cancers. So it is effective only in few cancers, not the whole list which we were using for the cisplatin. Now, this was about the first conventional chemotherapeutic drug. Now we'll move on to the second one. This is methotrexate. And FDA approved methotrexate for cancer treatment in 1953. It's almost almost 70 years before the FDA approved it. And it is an antimetabolite of folic acid, and it is a methylated aminopterin. So the aminopterin and methotrexate came almost simultaneously, but later the methotrexate was preferentially used because the side effect profile was better with methotrexate when compared to aminopterin. So we are mostly using methotrexate nowadays. So it is a dihydrofolate reductase inhibitor. So what this DHFR, or the dihydrofolate reductase enzyme, does is that it converts the inactive folic acid to active tetrahydrofolate. And this active tetrahydrofolate is essential for your purine nucleotide synthesis. So if this purine nucleotide synthesis doesn't happen, your cancer cell division will not happen and the cancer cells are affected. So that is the theory behind how this methotrexate works. And we are more worried about when you are using methotrexate as high doses. That is, high dose is usually 1000 milligram per meter squared, and even 500 milligram per meter squared, you can say it as high dose. And primarily, the renal excretion is the main way of getting rid of your methotrexate. So hence the toxicity with the methotrexate. And how does methotrexate produce your AKI? It crystallizes in your distal tubules. So that's the most important thing. It crystallizes in your distal tubules. And then there can be direct tubular toxicity. And then there is oxygen-free radicals reducing the adenosine deaminase activity. And then there is a hemodynamic effect resulting from an afferent arteriolar constriction. Usually methotrexate produces non-alluric AKI and usually peaks within 1 week. So that is the way in which AKI happens in a methotrexate. So how can we prevent it? Usually it is alkalinization. So our oncology or hematology colleagues are very particular regarding this, and they don't usually consult us for these things. They usually alkalinize the urine. They give to keep the urine pH more than 7, and they give leucovorin or folinic acid rescue depending on the methotrexate levels. And one thing that has come up recently is that there is a recombinant enzyme, that is glucarpidase, which hydrolyzes the methotrexate into inactive metabolite. And the result is that it can reduce your methotrexate by more than 97% within 15 minutes. So it rapidly reduces the methotrexate levels. And previously it was the dialysis, which was the only modality which could reduce the blood levels of methotrexate. But now we have a recombinant enzyme, just like your raspberry case, you have a recombinant enzyme which can cleave the methotrexate and reduce the levels drastically within a short period of time. And classically, high flux HD has been shown to reduce your methotrexate, but nowadays we don't use hemodialysis as a modality for methotrexate toxicity unless there is other indications, aka indications for dialysis. So we all know about methotrexate as a conventional agent, but I assume that at least few of you may not be aware of a drug called pemetrexed. So pemetrexed is a methotrexate derivative, so it's a multi-target antifolate, just like the methotrexate, but it mainly acts on the thymidylate synthase, unlike the direct DHFR in methotrexate. This also acts on the pemetrexed also acts on the DHFR enzyme, but main action is on the thymidylate enzyme. So the mechanism is almost the same. Renal excretion is through the kidneys, and pre-treatment with folic acid prevents the risk of AKI. And caution should be advised when the GFR is around 40 ml per minute. And we usually get consultations for clearance for giving pemetrexed when the GFR is around 40, and they ask for our clearance for giving pemetrexed. Usually it's not recommended when the GFR falls less than 40 ml per minute as per the guidelines. So we'll move on to the next agent. So ifosfamide, we all know about cyclophosphamide. It's a congener of cyclophosphamide. It's a nitrogen mustard alkylating agent. It is nephrotoxic compared to your cyclophosphamide. Cyclophosphamide is not nephrotoxic per se, but ifosfamide is nephrotoxic. It is metabolized to acrolein, just like your cyclophosphamide, resulting in your hemorrhagic cystitis. So acrolein causes your hemorrhagic cystitis, just like in your cyclophosphamide. But in addition, the ifosfamide has something called as a chloroacetaldehyde as a metabolite. And this chloroacetaldehyde causes the kidney injury in ifosfamide, which is not there in cyclophosphamide. So if I show you the image, if you look on the screen, the ifosfamide comes up from the circulation into the proximal tubular cells through the same OCT channels, the organic cation transporter. And once it gets into your proximal tubular cells, it is metabolized into acrolein, which goes out into your urine and produces your hemorrhagic cystitis. And the chloroacetaldehyde remains inside your proximal tubular cells and produces the proximal tubular injury and hence the AKI. So it's associated with ATN because of the tubular injury. Then renal tubular acidosis, Fanconi syndrome, and hypophosphatemia can be so severe with ifosfamide, sometimes if the Fanconi syndrome is severe. And though the cyclophosphamide produces a SIDH kind of a syndrome, ifosfamide can produce a nephrogenic diabetes insipidus. So that also should be kept in mind. So I was just talking about a couple of maybe 3 or 4 conventional chemotherapy drugs, but we have a lot of conventional chemotherapeutic drugs. Like the list is shown on the left side: gemcitabine, capecitabine, melphalan. All these are known to us. We know the names, but most of the drugs have kidney injury potential also. So we have to be careful. For example, in gemcitabine, you have to be thinking about thrombotic microangiopathy also. So all these conventional chemotherapeutic drugs can produce AKI. So this was about the conventional chemotherapeutic drugs, which targets the rapidly dividing cells. So it is mainly targeting the rapidly dividing cells. It's not just the cancer cells. It affects almost all the rapidly dividing cells. But what if we could target the cancer cells per se? So that is what is being utilized in this targeted therapy. So in targeted therapy, we are targeting certain proteins which are found on the cancer cells, so that it is very targeted compared to a conventional chemotherapy. And immunotherapy, unlike the targeted therapy, what we are doing is that usually the cancer cells inside your body is not being attacked by your T cells or the immune system. But we somehow want to enhance your immune system so that these T cells can attack the cancer cells. So that is being done with the immunotherapy. So we'll see the examples later. So on the left-hand side is a busy list of the different, what Madam was saying, every day a new drug is coming, new NIPs are coming, new MAPs are coming, monoclonal antibodies, everything is coming. The list grows every day. So this is not an exhaustive list. It's a few of the drugs which are used in targeted chemotherapy. And probably this is the drugs which we commonly see in our onconephrology practice. with the examples given here. So we'll see that the different targeted proteins or the enzymes which are utilized in targeted chemotherapy. So the proteasome inhibitor, we are very familiar with our bortezomib, carfilzomib, isazomib. All these proteasomes proteasome inhibitors can be utilized in your multiple myeloma. Then you have the VEGF pathway, that is vascular endothelial growth factor pathway, where you can see that the multiple areas can be looked into. That is the VEGF antibody, that is bevacizumab, directly acts on the VEGF. And then you have the VEGF receptor antibody, that is the receptor is blocked by the antibody. So I have the axitinib or the ranibizumab. Then you have the VEGF trap, that is the soluble receptors are available which can bind the VEGF and is removed from the circulation. So example is aflibercept. And then you have the downstream pathways inhibited using tyrosine kinase inhibitors. Examples include sorafenib, pazopanib, and lenvatinib. So what do you see as a renal side effect with this anti-VEGF treatment is new or worsening hypertension, AKI, and proteinuria. And the proteinuria can be as severe as a nephrotic range proteinuria. And with pazopanib and lenvatinib, especially with lenvatinib, the hypertension incidence can be as high as 70%. That's what the literature says. So our oncology colleagues are very aware of this, and they look at the blood pressures and they ask the patients to look at their blood pressures at home when they start the patients on lenvatinib. So we also should be aware regarding these side effects of these drugs. And as anti-VEGF treatment, it can produce thrombotic microangiopathy as well. Now, epidermal growth factor receptor antagonists are there as a targeted therapy. You have your cetuximab, the classical one is cetuximab. And the classical description of a kidney-related problem is hypomagnesemia with the cetuximab. And the renal wasting is due to the inhibition of the TRPM6 protein, the channels that are present on the apical to the tubular side of the proximal tubular cells, because these epidermal growth factor receptors are needed for the reabsorption for the TRPM6 channels to be attached to the apical membrane. If it is not done, the TRPM6 channels are not on the apical membrane and the magnesium reabsorption cannot happen. And this will result in magnesium wasting through the urine and resulting in hypomagnesemia with cetuximab. So then you have your human epidermal growth factor receptor 2 antagonist. So trastuzumab and pertuzumab. There is no reported renal toxicity. The only thing is that when they are used with the anthracyclines, they can produce cardiorenal kind of a syndrome. So the renal effects can be because of that. No direct renal toxicity per se. And then you have your BRAF inhibitors, which AKI can happen. It's not very common. Usually it can be delayed up to 2 months, and the main cause is tubular injury. And then you have your BCL2 inhibitors, that is venetoclax, that is widely being used nowadays for your leukemias and lymphomas by your hematology colleagues. And this can also produce tubular injury and creatinine rise. So this was regarding the targeted therapy. I just went through the common examples and the common problems that we see with the targeted therapy. I have not gone into the very details of the targeted therapy. These are the common ones, at least we should be looking out in our clinical practice. So then you have your immunotherapy. As I told, your cancer cells are not being attacked by your T cells. So this is because there are certain checkpoints that are present on the tumor cells that will not allow the T cells to kill them. So these checkpoints can be in the form of a programmed cell death protein or PD-1. Then you have the programmed cell death protein ligand, PDL1, which is present on the tumor cell. And then you have your CTLA-4s. So if we could inhibit these checkpoints, then your T cells could attack the cancer cells and the cancer cells can be destroyed. So that is the main the reason why the immunotherapy was created. So then you have your PD-1 inhibitors. The common ones are the pembrolizumab and the nivolumab. And then you have a PD-L1 ligand inhibitors, atezolizumab, there is a classic one being used. And then you have your CTLA-4 inhibitors like ipilimumab. So all these will help us in targeting the cancer cells with your own immune system. So this is an example. So here you can see that the PD-1, this is the PD-1, this is present on the T cell, and this binds to the PD-L1 ligand on the cancer cell. And once it is attached, the T cell is not able to kill the cancer cell because it's a checkpoint. So what if we could inhibit this checkpoint? So there's a monoclonal antibody coming and binding to the PD-1 or a PD-L1, that is the ligand. If it is binding, it cannot be activated. So then your T cell can destroy the tumor cells, and that can result in resolution of the cancer. So that is the theory behind the use of checkpoint inhibitors. So when you're talking about checkpoint inhibitors, your main thing is immune-related adverse events. So it mainly affects your skin, dermatology, then you have GI side effects, then you have hepatological, that is liver-related, immune-related adverse events, then you have your endocrinological-related adverse events. But renal is less when compared to the other system involvement with immune-related adverse events. And the renal part, the biopsy finding that is most commonly seen with immune checkpoint inhibitors is acute tubulointerstitial nephritis, and sometimes it can present with nephrotic range proteinurias also. And the treatment is usually steroids when the AKI is very high or the proteinuria is very high, and stopping the drug definitely. And oral prednisolone can be given as 0.5 to 1 milligram per kilogram per day. And renal biopsy may be needed if you have a doubt regarding whether it was just the checkpoint inhibitor which produced the kidney injury, if there was something else, or if there is severe nephrotic range proteinuria which is not improving after stopping the checkpoint inhibitors, you may have to think about a membranous nephropathy as a paraneoplastic syndrome. You may have to do a renal biopsy to confirm things. So otherwise, most of the times it improves with stopping the checkpoint inhibitors, and sometimes a short course of low-dose steroids will improve the renal adverse events. So a few words regarding CAR-T therapy. I'll not go into the details. It is chimeric antigen receptor T-cell therapy. So what they do here is that the patients on T-cells are removed from the body after increasing the T-cell production in the body, and then it is sent to a lab. It's not done here. It's sent to a metro city where in the lab it is reprogrammed so that it can specifically attack the cancer cells in the body. For example, if the CD19 cells needs to be, the cell which contains the CD19 needs to be attacked, it will modify, in the lab, it will modify the T cells so that T cell will specifically, that is a CAR T cell, will specifically attack the cancer cell. So once it is ready, it takes almost like 2 to 3 weeks for the CAR T cells to be created. And once it is ready, it is shipped back to the hospital and it is infused into the patient, and the CAR T cells directly goes to the cancer cell and it destroys the cancer cell fully, rather than having the effect on other cells. So when you're thinking about CAR T cell therapy, the major problem with it is cytokine response syndrome, which can result in AKI also. And a few words regarding hematopoietic stem cell transplantation. Here also the same thing, the stem cells are harvested from the blood of the patient or from a donor. And then once it is harvested, then you give the chemotherapy so that your bone marrow is obliterated, the immune system is obliterated. Then you infuse back the hematopoietic stem cells into the patient. And it takes 1 or 2 weeks, at least 1 week, for the engraftment to happen. And once engraftment is there, the patient will be on cyclosporin or a CNI in the post-transplant period. And so you have a picture almost like your kidney transplantation in hematopoietic stem cells. So you have immunosuppression resulting in sepsis, infections, everything contributing to the AKI in the initial period. Then you have your engraftment syndrome, which can produce AKI. Then you have your calcineurin inhibitors in the post-transplant period, which can have AKI risk. So all these come into play just like your kidney transplant in hematopoietic stem cell transplantation. So I'll just give a few more examples of how difficult it is for us to be updated regarding onconephrology, and how important it is to remain updated regarding onconephrology. So 2 weeks ago, I get a consultation from our onco surgeon asking for a nephro clearance for HIPEC. So if it was 2-3 years ago, I didn't know about HIPEC, but luckily I had a patient, so I knew about HIPEC. So what is HIPEC? So initially, when it was, I was hearing it for the first time a couple of years ago, I didn't know whether it was a drug, what it was. So HIPEC is hyperthermic intraperitoneal chemotherapy. So what they do is that it is useful for patients who have cancer with peritoneal metastasis. So you do a cytoreductive surgery to remove the macroscopic peritoneal tumor deposits, and thereafter you pass heated solution of chemotherapeutic drug into the peritoneal cavity to address the microscopic residual disease. So our role comes because one of the most common drugs used in this HIPEC is cisplatin. So this cisplatin, when it is given as a concentrated solution into the peritoneal cavity, it can produce AKI. And how I came to know about this HIPAC is because one of our staff nurses had ovarian cancer, and she underwent this CRS, that is the cytoreductive surgery, and HIPAC in an outside center. And she developed a cisplatin-induced AKI, and the creatinine went up to 5. And it came down to 2, but over the last 3 years, it has remained 2. It has produced a progressive disease, and the AKI has not resolved. So I knew about this just because I had a previous experience. But luckily, so since I had that experience, when the oncosurgeon sent for this clearance, at least I knew the name of HIPAC. So another one is usually nowadays I get a consultation for hypokalemia with abiraterone. So previously, when I heard about hypokalemia with abiraterone treatment, the oncology team calls us for hypokalemia with abiraterone. The first time when I heard it, I didn't know what abiraterone was. So it is used for prostatic cancer. It irreversibly inhibits your cytochrome 17, that is your 17 alpha hydroxylase and 1720 lyase enzyme, which blocks the androgen synthesis. So it is basically blocking your androgen synthesis. So what happens is that this is the usual disease seen with the cortisol and the testosterone and everything. So abiraterone, it inhibits the 17 alpha hydroxylase enzyme here, and then the 1720 lyase enzyme here. So the androsterone or the testosterone production is inhibited. So this pathway is inhibited. But the problem is that there is more of deoxycorticosterone, more of corticosterone. So that will act on your mineralocorticoid receptors, resulting in hypokalemia. The other thing is that since your cortisol is also on the lower side, that is the ACTH, the feedback is not there. So ACTH levels go up. So again, the ACTH also drives more of this pathway, but it is not going down this pathway for the testosterone. More of deoxycorticosterone and corticosterone is being produced, resulting in worsening of your hypokalemia, hypertension, and fluid overload. So what they usually do, the oncologists know about this, though we may not be knowing about this, but they know about this ACTH suppression. So that is needed. So they give prednisolone 10 milligram or 10 milligram BD or 10 milligram OD for these patients to suppress the ACTH. So that's what they usually do. And when they come to us, we usually have to supplement with the potassium supplements, and then sometimes we give aldactone, sometimes it works. So amyloidase also can be tried. So my last case was for a consultation, we get consultation from the oncology team with AKI for olaparib. So olaparib, it's a PARP inhibitor. So it's a poly-ADP ribose polymerase inhibitor. So it's routinely being used, and we get consultations for olaparib. So when you think about a patient on olaparib, the first thing that should come to your mind is that it can produce pseudo-AKI. So it inhibits the creatinine secretion. So here you can see, again, I'm going back to your OCT channels. There is a blood site. So the creatinine goes into the proximal tubular cells with this OCT channels. There is organic cation transporter, and it goes out into the urine using your MATE channels. There is a multi-drug and toxin extrusion transporter. So it goes out into the urine. So what happens with the olaparib is that it inhibits, olaparib inhibits the OCT channels as well as the MATE channels. So this creatinine secretion is not happening. So you can get mild elevations in creatinine, and you usually get consultations on when the patient's creatinine goes up when the patients are put on olaparib. And we should be aware that it can produce pseudo-AKI. So there are multiple drugs that can produce pseudo-AKI in the clinical setting. What I have seen is ribociclib, which can produce your creatinine rise. And the olaparib is also a common one. So what I would say is that all these things are very important, but if one thing as a general nephrologist, if we have to take home is that hypomagnesemia is very common in oncology. I was surprised to see that it is not just the chemotherapy drugs, the patient's dietary restrictions, or the patients are not able to eat well because of their anorexia. And then the patients can have mucositis. All these might be contributing to the hypomagnesemia. So I think we are not very used to doing magnesium levels. We always go with the sodium, potassium, calcium, uric acid. We are aware of the TLS, tumor lysis syndrome, and everything. But hypomagnesemia is something we should be looking into most of the patients with who are coming to us for onconephrology consultations. And new drugs are coming every day, and you should be ready to learn. And the other important thing is that your oncologist or your hematologist may know the renal issues of a drug more than you. And it's we should be updating us very rapidly